well, your books may not, but some books actually call it hypernephroma. And we see that it is the most common renal neoplasm, and that it occurs predominantly in patients that are older than 40 years old, and the median age for diagnosis being around 64 years of age. When we see that it often begins with painless hematuria, then progresses from there. And the tumor usually originates in the tubular epithelium of the renal cortex. Okay. So renal cell carcinoma accounts for approximately 30% of all adult malignancies, and around 90 to 95% of all neoplasms arising from the kidney. So pretty much when someone says that they had cancer of the kidney, there's a high probability that that is actually renal cell carcinoma. We see that this disease is characterized by lack of early warning signs, diverse clinical manifestations, and resistance to radiation and chemotherapy. Pretty much the only thing that they have found that actually works for renal cell carcinoma is a radical nephrectomy, which means that you can basically take the kidney out and remove it from the body. And we see that it is pretty effective for stage 1 renal cell carcinoma, with a 5-year survival rate being around 94%. Patients with stage 2 lesions have a survival rate of around 79%. And so we'll find out that as the disease progresses and it spreads itself to more and more areas of the body, we see that it actually will drop the survival rate down to almost nothing when you get into stage 4. We see that from 1975 to the year 2006, the incidence of kidney cancer rose around 2% annually in the United States. And an interesting thing is that renal cell carcinoma is more common in people of Northern European ancestry. And we also see that renal cell carcinoma is the 10th leading cause of cancer deaths in males in the United States. In men, deaths from kidney cancer decreased 3.9% between 1990 and 2005, but in women, it decreased by 7.8% in the same period. So while men have been shown a steady decline in the amount of deaths and discoveries, women have been doubling that. And so the incident rate for women is decreasing at a much higher level than men. And no one really understands what is actually causing that decrease. And we see that unfortunately the 5-year survival rate for patients with stage 4 disease are extremely low, to around 0 to 20%. And have you guys ever been around anyone that has renal cell carcinoma? Which stage were they in?
I'm not sure, but he must have been in 1 because he lived about 10 years after.
Good. Actually, one of the security guards that was at the facility that I worked at, he was diagnosed with renal cell carcinoma stage 4, and it is the strangest way that he found out that he had renal cell carcinoma. He was big into lifting weights, and so he was at the weight room doing bench presses, and I think he was around 46 when he actually found out. He was doing bench presses, and he was laying on his back lifting weights, and he was pushing up, and he felt a pop in his chest. He didn't think anything about it. He thought maybe he had fractured his sternum, just by some chance. So he goes to the doctor. The doctor says, well, let's get some images of him. So they do just a normal chest x-ray, things like that. It comes back inconclusive because they're not really ideal for demonstrating sternums. So they order a CT chest. And they do a CT chest, and they find out that he has basically no sternum. The cancer has pretty much invaded all of his sternum. His sternum was ate away into where there's just very little calcification and basically a tumor lying where his sternum would be. And when they did further scans, they found out that he had cancer in his kidney. And so he went to several hospitals, and they found, and one hospital basically wrote him off, said, go home, borrow your he actually went down to another hospital, and they started treating him with it's like experimental treatment. I really don't know what it is, but he lived, I think, 2 years afterward. And his disease, when they got to looking at it, it had progressed to his mediastinum, to his lungs, and they had pretty much eradicated by the time he died the tumors in his lungs. They were shrunk down to next to nothing. They had removed his kidney, I think it was his right kidney, with radical nephrectomy, and they felt that they had everything in progress, that everything was going good. However, one night, he comes into the ER and is having seizures. And we did a scan on him that night, and he actually had 5 tumors in his brain from the renal cell carcinoma that had finally just mets everywhere. And before, I'm sure they had done scans of his head before and nothing was there, but the disease had just progressed, even though they had removed his kidney. And he had 1 tumor, or 2 tumors behind his eye, and his eye was basically from that point on closed, and he couldn't open his eye. He had 3, I think, in his head, and 1 was hemorrhaging, and so it looked bright white, had tons of blood flow to it, and I think he lasted probably 3 or 4 months after that scan, and he died. But stage 4 renal cell carcinoma is a very, very traumatic thing, and you see that survival factors are just based on these things, and that a long disease-free interval between initial nephrectomy and the appearance of metastasis. So if a person is in stage 1 and they don't experience any metastasis, that is a really good prognosis indicator there. We also see that the presence of only pulmonary mets are another indicator of a good survival rate, because they can actually treat those pulmonary mets. And we also see good performance status, means that you're compliant to all the therapies and things that they're giving, and also removal of the primary tumor. So if they can accomplish these things while you're at a lower stage, then you have a very good prognosis. However, as it continues on, your prognosis actually goes down. And so the causes for renal cell carcinoma are very widespread. We see that cigarette smoking actually doubles the risk of renal cell carcinoma and contributes to as many as 1/3 of all cases. So yet again, we see that smoking is just not tied to lung cancer, or esophageal cancer, but it actually extends itself even into urinary cancers. We also see that obesity is another risk, particularly in women. Hypertension and phenacetin-containing analgesics. And on the guy that passed away with renal cell carcinoma, he always said, and his doctors believed, that he was in Operation Desert Storm. And sometime, I forget if he was Special Forces or something, but they were in a radioactive area. And he always maintained that it was because of him being in a radioactive area for a pretty decent amount of time that actually caused the renal cell carcinoma to actually happen. Whether that's true or not, we don't know. But we see that there is a varying degree of causes for renal cell carcinoma.
VA monitors the Desert Storm vets that didn't go to VA monitors their kidneys very closely.
Really?
They were exposed to something.
Really. So, there very well could be something to that no one actually knows what is a cause of renal cell carcinoma among these people that would not have it. And if I'm not mistaken, in his team, there was a high incident rate of renal cell carcinoma based on the people that he was around. A lot of them had already passed away with it. And so we see that the classic presentations of flank pain, hematuria, and flank mass, all in conjunction with each other, are very uncommon. If all these are present at the same time, we see that it is very indicative of advanced disease. So if you have all of these at the same time, probably the disease is very advanced. And the most common individual symptoms are hematuria, flank pain, palpable mass in the flank or abdomen, weight loss, fever, hypertension, hypercalcemia, night sweats, malaise. However, we see that 25 to 35% of all patients are asymptomatic, meaning that they're not experiencing any symptoms. And that is the case with him. He had experienced no symptoms of renal cell carcinoma except the fact that he was lifting weights and heard the pop. If he hadn't heard the pop, then he may have never knew that he had renal cell carcinoma until it was extremely too late. So the workup for diagnosis is basically our standard workup procedure. You have a UA, CBC, and a renal profile, which you could just say renal profile as being included with a comprehensive metabolic panel, OBDBUN levels, as well as creatinine levels and GFR. CT is considered the most accurate method of detecting local and regional spread of renal cell carcinoma. So not only will CT demonstrate renal cell carcinoma, but it will also demonstrate where it has possibly mets to. We'll also see MRI and ultrasound. However, ultrasound is not as effective as CT or MRI in this case. And so when you're looking at it on CT, you see that large tumors greater than 3 centimeters are heterogeneous and multilobulated. And so that goes back to unifocal and things like that. We see that multilobulated will mean that you have an area and it's got several divisions in it. So that would be multilobulated. And we also see that they're non-communicating. And so if we erase this, that would be communicating, because this one and this one have an opening between them. However, if you were to redraw those lines, that means that they have no communication in between them. And so that's what we're talking about there. And we also, in diagnosing renal cell carcinoma, look for mets into the lungs, mediastinum, bone, liver, contralateral kidney, meaning the opposite kidney, adrenal glands, and brain. And so this is our first image of renal cell carcinoma. So does everyone see kind of the weird appearance to the kidneys? It's kind of where the arrows are pointing. It looks like a cystic mass. And this is an excellent image because on the left kidney, we actually do see a cyst. This is a person probably has 2 cysts. They have one here and one here. However, this over here and this are bilateral renal cell carcinomas. And so this person, this is a bad situation to be in because you have bilateral. And the way to treat this is nephrectomy. So if you remove both kidneys, then the patient is going to be in severe trouble.
What is this, sir? What is this, sir?
That probably is bowel, just the way it's layering in there. If we had the ability to scroll down and scroll up, we could probably see that that's bowel underlying the cyst, and the cyst is laying right on top of the bowel. You're just not being able to catch it. Or it is part of the kidney, but without the ability to scroll down and scroll up. And that is one of the key things that you do on CT is you scroll down and keep scrolling up, and it allows you to differentiate between, bowel, kidney, things like that. But for the sake of this image, we'll say that that's probably bowel or kidney. Could be contrasted kidney with another cyst lying up anteriorly. But either way you cut it, we see that the patient has 2 or 3 cysts on the left kidney as well as renal cell carcinoma bilaterally. So that is one manifestation of renal cell carcinoma, and you can see how it's highlighted by the contrast. Here is another renal cell carcinoma, and this one is very enlarged. And we see that it has septations as well. We have the beginning of septation here between the two, and we see that it is heterogeneous. meaning that it has two densities inside of it, not just one. Whereas a cyst will have just one density, this has two densities in it. We see that the contrast is actually highlighted the wall, and it has actually highlighted some of the portions inside of the renal cell carcinoma, indicative of blood flow going to the tumor. Here is also another renal cell carcinoma, and this is one that is a little more difficult to determine. It kind of gets lost on this image. Can you guys see a little bit of change in attenuation on it? A little bit. On this monitor, there's actually a line that is running here, and you have the darker being the more posterior portion of it, and the anterior portion is actually a little wider, and so that just demonstrates that it's heterogeneous and it's not a simple cyst on the kidney. And also, this has kind of a lobulated appearance, meaning that it's not smooth. It's got an indentation here, and it's got a weird shape on the back side of it as well. And so this is not just simply a smooth, simple renal cyst. And probably this person is a stage 1 or stage 2, just based on the size of it. And this person is probably in a more later stages of it. So does anyone have any questions on renal cell carcinoma? So how can you determine between a cyst and renal cell carcinoma? Anybody know?
Cysts have a uniform density.
Uniform density. Good. And so what does renal cell carcinoma have? Multiple densities. Okay. So, as you know, contrast is one of the best indicators for renal cell carcinoma. It's unlike renal stones and things of that nature. You actually need to inject contrast for this. Okay. Wilms tumor. Wilms tumor is also called nephroblastoma, and it's the most common childhood abdominal malignancy. And at present, survival rates of children with Wilms tumor are approximately 80 to 90%. And this is in contrast to the rate of 50 years ago, when only 10% of children survived. So medicine has made really amazing progress in terms of survival rates for the children. We'll also see that it affects approximately 10 children and adolescents per 1 million before the age of 15. And it accounts for 6 to 7% of all childhood cancers in North America. And so, Wilms tumor is thought to be caused by alteration of genes responsible for normal genitourinary development. And examples of common congenital anomalies associated with Wilms tumor are cryptorchidism. And so, what cryptorchidism means, if you break it down, crypto is used in the word encrypted. Encrypted means to hide something in something. And so crypto just means hidden. And orchidism is in reference to the ovaries or testes. And so basically hidden ovaries or testes, like undescended testes in kids and male kids. We also see double collecting system, horseshoe kidneys, hyperospadias, things like that are all indicative of Wilms tumor. We see that the most common symptoms are just asymptomatic with a palpable abdominal mass, and that occurs in 80% of children. We also see abdominal pain and hematuria manifested in children. And the way to determine this is simply a physical exam on the most part. It often reveals a palpable abdominal mass, and upon determining this, then you can determine the other tests that need to be ordered. A lab test such as CBC, comp, and UA, this once again is to rule out urinary tract infection. Chest x-ray to make sure that there is no metastatic disease in the lungs. Ultrasound of the renals, simply because it doesn't require any radiation, and that's why ultrasound and MRI are typically pushed as a determining factor of Wilms tumor more so than CT because of the radiation dosage that you save by ordering ultrasound and MRI. So we just go by the stages on CT because CT is typically used for staging and not determination of it. We see stage 1 cancer is found in only one kidney and can generally be removed with surgery. Stage 2, cancer is spread to the tissues and structures near the affected kidney, such as fat or blood vessels, but it can still be completely removed by surgery. Stage 3, the cancer is spread beyond the kidney area to nearby lymph nodes or other structures within the abdomen, and it may not be completely removed with surgery. Stage 4, the cancer is spread to distant structures such as the lungs, liver, bones, or brain. Stage 5, cancer cells are found in both kidneys. And so CT is just typically used for a staging procedure in terms of Wilms tumor. And so this is what it actually looks like on CT, and basically all that you need to know about this image is that based on the patient's body habitus, you can determine that this is a small child or not an old child at all, just because it's very, very tiny. And things aren't fully formed, such as the vertebrae, totally rotten. And so because it's a kid, you can just say that it's probably a Wilms tumor because you see the left kidney and the right kidney should be visible as well, and it's actually attached to it. There's really no way of determining Wilms tumor on this. You just see that it is not homogeneous, but it's actually heterogeneous. It has contrast enhancement, and it has septations. And because most renal cell carcinomas occur after the age of 40 with a median age of 64, we know that this person doesn't have renal cell carcinoma because they are a young child. And so it is Wilms tumor. And so basically, if you see a cancer on the kidneys in kids, it's Wilms tumor. If you see it in adults, then it's probably renal cell carcinoma. That's just basically the division there. And this is also another child. And this person probably, we don't see the right kidney, but from the organs that we do see, this person would probably be in stage 1 or stage 2. So basically, what I would do on a test would put an image like this on there, but I would like to be able to see both kidneys. And since you see that there's nothing in the livers, there's nothing in the lungs, things like that, you can say that it's probably 1 or 2, stage 1 or 2. And the question would be, what stage is this patient in? And I would put like stage 2, stage 3, stage 4, stage 5. I would eliminate the stage 1 because there would be some hesitancy there between 1 and 2. And so the obvious answer would be stage 2. And once again, you can tell that this is not just solid mass, but it actually is a heterogeneous mass. It has a large amount of blood flow, and you can see some areas that are contrasted and some areas that are not. Some areas that are extremely hypodense and others that are not as well. So does anyone have any questions about Wilms tumor? Okay. Bladder carcinoma. We see that bladder cancer is a common urologic cancer, and almost all bladder cancers originate from the urothelium, the 3 to 7 layer cell mucosal layer within the bladder. 90% are transitional cell carcinomas, or TCCs, 5% are squamous cell carcinomas, or SCCs. And it's believed that development of SCC is associated with persistent inflammation from long-term indwelling Foley catheters and bladder stones and possibly infections. So they have kind of tracked down squamous cell carcinomas to the extent of being or stemming from Foley catheters, bladder stones, and infections. And bladder cancer has the highest recurrence rate of any malignancy. So basically, people that have bladder cancer could possibly always have bladder cancer. There's a high incident rate of recurrence there. And bladder cancer is the 4th most common cancer in men in the United States, after prostate, lung, and colorectal cancer, whereas bladder cancer is not even among the top 10 cancers in women. So as we see here, it is a high rate among men and not so much among women. So meaning that it prefers or has shown preference to men than women. And the incidence of bladder cancer increases with age, with the median age of diagnosis being around 68 years of age, and it's about 4 times higher than in men than in women. And the recurrence rate for superficial transitional cell cancer, or TCC, of the bladder is high. It occurs in as many as 80% of people, and they at least have one recurrence. We don't have the statistics on people who actually have more than one recurrence. So we see up to 80% of bladder cancers are associated with environmental exposures. Tobacco use is the most common cause. And speaking of tobacco use, we saw tobacco use pop up in some of these other cancers as well. And one study that I was reading about kind of attributed it to the fact that when you smoke, it gets into your bloodstream. And when it gets into your bloodstream, your kidneys have to filter that out. And when your kidneys have to filter out all the waste that are in your bloodstream, then it winds up getting into your bladder. And when it's in your urine and it's in your bladder, you have to excrete it. If you have it in your bladder for a long period of time, it can actually cause cells in your bladder to mutate. And so that's what kind of they're talking about, environmental exposures. And so one would have to wonder if that is the case, then that could be attributed to a lot of cancers in terms of your renal system. We'll also see that occupational exposure to aromatic amines or aniline dyes is presumed to be the cause of bladder cancer in as many as 25% of all the cases. And these are people such as diesel mechanics, petroleum product producers, and people who produce solvents. We also see exposure to organic chemicals has been reported as a risk as well, such as beauticians, dry cleaners, painters, people like that all seem to be at risk as well for bladder cancer, just simply because of what they're around each and every day. And we see that approximately 80 to 90% of patients with bladder cancer present with painless gross hematuria, and that is the classic symptom. Other symptoms include dysuria, urgency, or frequent urination. Okay, so typical workup, lab tests are usually inconclusive, but one of the most used tests could be a UA. Cystoscopy is also utilized, and the beneficial thing for this is it is low risk, and biopsy specimens can be taken when performed. Okay, we also have CT abdomen pelvis, and the American Urological Association recommends this with contrast. Ultrasound, commonly used, but can miss urolithial tumors of the upper tract as well as small stones. So that is kind of a chink in the armor for ultrasound, and kind of why CT is more preferred. We see that CT is performed with full distension of the bladder, and when doing this, this demonstrates a neoplasm as a mass projecting into the bladder. It also demonstrates as a focal thickening of the bladder as well. We see that delayed scans show a soft tissue filling defect on the background of a high attenuation, contrast enhanced urine. So we go with the white on black theme again. The urine will be extremely white. It will have a high attenuation because of the density of contrast injected. And the soft tissue density will be the black background to it. It will actually be projecting into it, and you'll see an indentation in a normal urinary bladder. So with that being said, this is what a bladder carcinoma looks like. And this patient is probably on the first or the contrast injection portion of the scan. It's not on the delayed images, because if it was on the delayed images, the bladder should be contrasted. However, we see that the mass is actually contrasted and the bladder is full of just unopacified urine. And so we can determine that whatever this is in the bladder has a very high metabolic activity because it, and blood flow activity, because it has absorbed contrast and it's held it against the urine. And you also see an indentation of the bladder, whereas this is actually the only portion of the bladder that is functional, and you have a mass that is kind of extenuating itself into the bladder. Another image of bladder cancer, and this one is more severe. This one is much more pronounced. This, once again, is on the contrast injection phase of the image without the delayed imaging. And the person has a fully distended bladder and allows you to really see the neoplasm projecting into the bladder. And it has, once again, absorbed contrast, and we see that it is a heterogeneous mass. You have areas of dark contrasted with areas of light. And this is just your standard axial scan. And here is almost the same image, but on a coronal plane. And as you can see, it has a high invasion of the bladder. I don't believe that these are the exact same images, but if they are, this one looks more severe than the previous one, because it seems like it has actually consumed more of the bladder. So does everyone see the mass in the bladder? Did everyone see it? Right. So pretty much anytime that you see anything in the bladder, such as this, it's going to be a bladder carcinoma. There's rarely anything else that would be like this, because it is invading the bladder. And on top of that, it is contrasted. So it has some degree of blood flow. Okay. So renal failure. Renal failure, or acute kidney injury, which some books are now calling it, is defined as an abrupt or rapid decline in renal filtration function. And it's usually marked by a rise in serum creatinine or an increase in BUN as well. And so we see that approximately 1% of patients admitted to the hospitals have acute kidney injury or acute renal failure at the time of admission. However, the estimated incidence rate of acute kidney injury is 2 to 5% during hospitalization. So if you actually think about that, that's kind of a staggering statistic, and kind of is alarming for patients going into the hospital, because 1% go in with acute kidney injury, and then 2 to 5% have it while they're in the hospital. So actually it increases while they're going to the hospital. So what are the hospitals doing that are causing this to increase? Could it possibly be medications that patients are getting? Because medications have a terrible effect of treating one symptom and then increasing something else. And so while you're treating someone for something, you exacerbate the renal insufficiency. We also said that the prognosis for patients with acute kidney injury or acute renal failure is directly related to the cause of renal failure and to a great extent the duration of renal failure prior to therapeutic intervention. And on the long-term follow-up, 1 to 10 years, approximately 12.5% of survivors of acute kidney injury are on dialysis and they're dialysis dependent. And this range varies from 1 to 64%, depending on the patient population. And 19 to 31% of them have chronic kidney disease. And so most of the patients who have acute renal failure wind up being dialysis dependent later on. And here we have a chart that basically gives you all of the baby blue boxes are things that can cause renal failure, either be it acute or chronic, and your darker blue are things that will be the result of renal failure. And as you see, some of the things are dialysis, transplant, and other complications. And so we see that there is a lot of things that can actually cause acute or chronic renal failure, and there are a lot of things that can actually be the result of it as well. And this is what I would call the vicious cycle of renal failure. You begin with renal failure, and then you have increased sodium retention because your body is not able to excrete it through the urine. And then because you have increased sodium intake, you have increased water reabsorption through the bowels, and so you have more and more water into the blood, and it has to go somewhere. So then you have generalized edema, you have swelling of the feet, swelling in the abdomen, things of that nature, because your body can't get it out, but it's absorbing. And then that goes into congestive heart failure. So because of renal failure, you wind up with congestive heart failure, and you have other symptoms that go along with congestive heart failure. And so, it's a steady downhill decline when you have renal failure. And there are 3 presumed causes of renal failure. One being pre-renal failure, the other one being intrinsic renal failure, and another being post-obstructive, or some books call it post-renal failure. And basically, pre-renal failure means that there is reduced blood flow to the kidneys. So if the kidneys have no blood to filter, then there is nothing that they can do. And this is a result of lower blood pressure, congestive heart failure, and renal artery stenosis. So there's no blood going into the kidneys, so there's no urine produced. Intrinsic renal failure is damage to the kidneys. And this can be caused by infection or necrosis of the kidney. And then we have the post-obstructive renal failure or post-renal failure. And this is caused by urinary tract obstruction. And so something such as a renal stone obstructing the renal system can actually cause or mimic the effects of renal failure. We see that there are a lot of symptoms here, and they vary in degrees. We have hypotension, volume contraction, congestive heart failure, nephrotoxic drug ingestion, history of trauma, things of that nature. But the ones to really focus on are those that are at a higher risk of developing acute kidney injury or acute renal failure. And these are the patients with hypertension, congestive cardiac failure, diabetes, multiple myeloma, chronic infection, or myeloproliferative disorder. And so lab tests to diagnose renal failure are BUN creatinine, which normally go with a comprehensive metabolic panel. Also a CBC and urinalysis to just analyze the urine and see actually what is made and what is in the urine. Ultrasound of the renals to look for renal artery stenosis, things of that nature. CT. And the good thing about CT is that it will possibly demonstrate a cause. For those with post-obstructive renal failure, things of that nature that could be due to an obstruction, CT will actually demonstrate that. And we see that contrast injection should not be performed as it could only further impair renal function. If someone has an elevated BUN and creatinine as well as a low GFR, I believe a GFR below 30 will actually be indicative of renal failure. And so if a patient has a GFR of around 5 to 10, that person is probably an excellent candidate for renal failure and could possibly be on their way for dialysis. And so contrast is something that they don't need to be absorbed into their bloodstream because it can only cause further problems. And there's not many CT images of renal failure. I just threw this one up there. You will not have an image of renal failure because they're not typically found. But as you can see, there's the kidneys, there's just nothing to them. These are the kidneys here, and there's really nothing to them. They're just atrophied to a point to where they're not functioning at all. So this is a person who is needing dialysis and probably dependent on dialysis. Prostate cancer. Prostate cancer is the most common non-cutaneous cancer among men. And it is the second most common cause of cancer death in males as well. And we see that prostate cancer develops when the rates of cell division and cell death are no longer equal, leading to uncontrolled tumor growth, meaning that cells are not dying off and they're being reproduced. 95% of prostate cancers are adenocarcinomas. And approximately 4% of cases of prostate cancer have transitional cell morphology and are thought to arise from the urothelial lining of the prostate urethra. An estimated 1 in 6 whites and 1 in 5 African Americans will develop prostate cancer in their lifetime, with the likelihood increasing with age. So we see that this is another age-dependent cancer, meaning that it gets higher as patients get older. We see that prostate cancer is rarely diagnosed in men younger than 40 years old, and it is uncommon in men younger than 50 years. So, once again, the younger you are, the less risk that you have for developing prostate cancer. We also see that prostate cancer is the second most common cause of cancer deaths in male after lung cancer. So lung cancer is number 1, and prostate cancer is a close second. And death rates from prostate cancer rose steadily from 1975 to 1991, remained level from 91 to 94, and has decreased since then. And that could be because of more and more early detection rates. More people are getting more exams, more CTs, more ultrasounds, things of that nature, as well as the physicians are doing an excellent job with their patients. And so they're actually catching it and diagnosing it at an earlier stage. We see that it's believed that there are genetic factors that increase the risk of prostate cancer because it's found to be higher in people of sub-Saharan African ancestry. And we also see that increased risk in Asians who have migrated to the United States suggests the importance of environmental factors, notably diet. So we see that genetic factors and diet could be things that play a role in this. And we also see that androgen ablation causes a regression of the prostate cancer. And this was found that eunuchs do not develop adenocarcinomas of the prostate, meaning that castrated individuals do not typically develop prostate cancer. So it's thought to be a hormonal cause as well as genetic. And currently, 47% of prostate cancers are identified in patients who are asymptomatic. But however, symptoms could include urinary frequency, and we see that is one of the big ones. Decreased urine stream, urinary urgency, and hematuria. Those are all some of the things that you will see typical of prostate cancer. However, we also see weight loss, loss of appetite, anemia, bone marrow suppression, bone pain with or without pathological fracture, spinal cord compression, lower extremity pain and edema due to obstruction of venous and lymphatic tributaries, nodal nets, can all be symptoms of advanced disease. And so we see that typical workup is a lab test as a prostate antigen, a PSA, and what a PSA actually does is it is prostate specific antigen, and it is released into the blood by the prostate. And healthy individuals have low levels of PSA in the blood, and when people actually have disease of the prostate, typical of cancer or enlargement, PSA levels go up, and they continue to go up until they reach a certain level where the physician steps in and says that it's basically too high, and then they do further testing on it, and then you see abnormalities such as cancer of the prostate. We also see MRI, CT, and transrectal ultrasound. Transrectal ultrasound has gained tons of steam and has almost become the preferred method of it because you can see the prostate and you can do such things as measuring, and it gives a really good indication of possible prostate cancer. CT is usually used for staging of prostate cancer, not used in discovery of prostate cancer, more staging. And we see that CT is neither sensitive nor specific enough to tell if it's a malignant prostate or not. However, typical findings on CT are enlargement of the prostate, but it could be caused by benign prostatic hypertrophy, tumor growth, or both. So just because the prostate is enlarged doesn't mean that it is malignant. CT also demonstrates nodules or straining densities in the periprostatic fat. We also see that the bladder could possibly have an indentation due to the enlargement of the prostate, and that is because the prostate has become so large that it presses on the bladder, and when it presses on the bladder, it causes urinary frequency, urinary incontinence, things of that nature. And this is basically an enlarged prostate. So does everyone see where the prostate is? You have the rectum to the posterior portion of it, and then just above the rectum, you have the prostate. So here's the rectum, and then right above it is the prostate. And so you can almost say that it lies around the symphysis pubis area. But as we can see from this scan, the person has obviously had oral contrast, and I would presume the patient has IV contrast as well, and we cannot see any enhancement, or if there is enhancement of the prostate, it's very minimal. And so you can't really determine whether this is malignant or benign prostate. The only thing that we can do on CT is just provide a measurement for the prostate. We can access axial, coronal, and sagittal images and provide a three-plane measurement, and that can provide the doctors with invaluable resources. Here's also an enlarged prostate. And this one actually on this screen looks like it has some degree of enhancement. Probably not accurate, it looks like that. But one of the other things that you can see is where the arrow is pointing. It actually looks like a lobulated mass sticking on the outside of the prostate with some straining. And so that is periprostatic straining that is going on outside of the prostate, these little areas here. And so that is typical of prostate cancer. But once again, that would be incredibly indeterminate for the prostate. Okay. Testicular cancer. Primary testicular tumors are the most common solid malignant tumor in men between the ages of 20 and 35 years of age. We see that the lifetime chance of developing testicular cancer is around 1 in 300, and the risk of dying is very low, about 1 in 5,000. we see that testicular cancers are not a common malignancy, meaning that in the entire lifespan of men, the chances of testicular cancer are very low. They're abnormal for men in varying other ages. So we see various risk factors have been associated with testicular tumors, but the specific etiology is not known. Possible causes are cryptorchidism, as we spoke of before, hidden or undescended testes. We see that also first-degree relatives have a higher risk of developing testicular cancer than the general population. So if someone of a close relation has developed testicular cancer, then someone who is just a slightly distant relative could have a higher risk as well. And we also see that men with male factor infertility are nearly 3 times more likely to develop testicular cancer. So associated symptoms of testicular cancer are just painless swelling or nodule of one of the testicles, dullness or ache or heavy sensation in the lower abdomen. And generally though, men never know they have testicular cancer until they do a self-examination. And so it usually goes missed for quite a while. And so the way to diagnose testicular cancer is simply a physical examination. It usually begins with an individual doing a self-examination, and then when they discover an abnormality, they go to a physician, and then it is followed up by a physician doing an examination. Ultrasound has been the primary modality of choice for demonstrating testicular cancer, and really all that is done in terms of CT for testicular cancer is a CT of the chest, and that is to look for pulmonary mets because testicular cancer has a high incidence rate of going to pulmonary, going to the lungs and being pulmonary metastases. We see that CT is not a modality to evaluate the presence of testicular cancer, but it can only aid in determining its progression. That is the primary use of CT. However, when a CT is done of the pelvis, we see that pelvic and retroperitoneal adenopathy is most pronounced on the side of involvement, and you can also see nodal enlargement near the ipsilateral renal hilum being a particularly profound characteristic. But there are really no images in terms of CT for testicular cancer. Then we get into ovarian cyst, ovarian cancer, and cervical cancer. And as we can see here, we have uterus, cervix, and then we have the ovaries out to the side. Those 3 are going to be our primary concerns, and as we will see, those are very, very difficult to delineate between the uterus and the cervix in terms of CT. It almost gets taken as one lump area because you really can't differentiate the area. However, the ovaries are extremely obvious in terms of their manifestation. So we'll just hit the high points on ovarian cyst. We see that ovarian cysts arising in the normal process of ovulation are called functional cysts and are always benign. And so that is an important thing to remember, that typically cysts are just a normal process, and normally they are always benign. There's nothing that makes them malignant. We also see that ovarian cysts are found on transvaginal sonograms in nearly all premenopausal women and up to 18% of postmenopausal women. So in terms of ultrasound, they are a common finding, and they're not that abnormal at all. We also see that multiple functional cysts can occur as a result of excessive gonadotropin stimulation or sensitivity, and tamoxifen can cause benign functional ovarian cysts that usually resolve following discontinuation of treatment. And tamoxifen is actually sometimes given in the treatment of breast cancer. And it interferes with the activity of estrogen, so it inhibits estrogen production. And associated symptoms of ovarian cyst. Most patients are asymptomatic. They never know that they have ovarian cyst. Some experience pain or discomfort in the lower abdomen. Torsion or rupture may lead to more severe pain. A lot of the times when you have patients with severe lower pelvic pain, we'll do a CT and you'll see that they have an ovarian cyst that is ready to rupture or has ruptured, and it'll have fluid in the pelvis. Torsion, actually my wife had torsion before, and her, I forget which ovary it was. I was going to bring her CT in, but I couldn't find it. One of her ovaries was enlarged. She had a mass on her ovary that was 22 centimeters by 22 centimeters, so it's pretty decent sized mass. And basically, when she got to UK, after a few days when they actually removed it, they had found that it had wrapped itself around the arteries, and they had to remove fallopian tubes, bilateral fallopian tubes, as well as one of the ovaries. And so she was in extreme pain. She said it was the worst pain that she'd ever had, obviously. And basically, the only way that I can describe torsion is basically like having a heart attack. And when you have a heart attack, you have decreased amount of blood flow to the area of the heart. And so when you have torsion, it basically clamps off the arteries, it clamps off the blood flow, and so you don't have blood flow to that, and so that tissue is dying. It is necrosing, just like the area of your heart that doesn't have blood flow. And so that is what torsion actually is. We also see that irregularity of the menstrual cycle, abdominal fullness and bloating, indigestion, heartburn, or early satiety is associated symptoms. We see that lab tests really have no diagnostic value in terms of ovarian cyst. We see that CA-125 is a really hopped up exam in terms of lab, but it is also a misnomer. We see that CA-125 is found in greater concentrations in cancer patients normally. Normal values are below 35 units per milliliter. However, CA-125 can also be increased during pregnancy in patients that have endometriosis, uterine fibroids, pancreatitis, normal menstruation, pelvic inflammatory disease, and even simple ovarian cysts can increase the rate of CA-125. And CA-125 has many times given both false positive and false negative results, meaning that you can't typically just rely on CA-125 to tell you whether it's malignant or benign. We also see that ultrasound is a very good indicator. MRI is actually superior to CT because it can provide delineation between what is ovary and what is bowel in CT. And so we see that normal ovaries are seen as soft tissue masses approximately 4 by 3 by 2 centimeters in size. Normal follicles are thin walled, low attenuation, smaller than 3 centimeters in size. Functional ovarian cyst, benign ovarian cyst, including follicular and corpus luteum cysts, are common incidental findings. They're well-defined, thin-walled, and have homogeneous density near water. They're less than 3 centimeters in size. And then benign cystic teratoma should have the presence of fat density, fluid, teeth, bone, hair, or fat fluid levels. But I will not ask you to tell me what type of cyst, whether it's functional, benign cystic teratoma, or things like that. You just have to know what an ovarian cyst is. And this would be an enlargement of the ovary. This is a decent sized cyst. I don't think I've done a scan on a patient that has had a cyst this big. This is probably 6 by 6 cyst. But as you can see, it is one solid density. It is just like a renal cyst, only in the lower pelvis. It provides the same attenuation factor like a cyst of the kidneys, and there's really nothing that is different from that. So if you know what a cyst in the kidneys looks like, then you just translate that down into the lower pelvis. Here's actually a hemorrhaging cyst. And as you can see, this entire area is the cyst, and you have this one little area in it. And this is a hemorrhaging cyst, meaning that something is happening to the blood flow on the inside of it.
How
But-
do you know that's not the bladder?
How do you know that's not the bladder? Here's the bladder. It always will be above the bladder. That's that's where you will see everything. I wish we actually had some scans to go by, and I'll see if I can track down my last scan. I think we may have actually gave it to another doctor's office. But it would be really beneficial to actually have some scans to scroll
I've got
through.
my
So you can
scan.
see- You got your scan?
Hers is awesome.
Great. All right. Well, we don't have much time.
It's
May have to
cool.
wait. May have to wait. Okay, so let's just look at ovarian carcinoma and what it actually looks like on CT. Okay. Here is what an ovarian carcinoma actually looks like. As you can see, here is the ovary, and here's another ovary. And this ovary, the left ovary, has actually gotten so big that it has actually pushed the right ovary away. It's kind of shoved it away. And as you can see, there are septations here. There's a septation here between the ovary and itself. And so this one probably is the carcinoma. And as you can see, there's something going on around it, some straining of fat that is lying around the ovary. And so that is probably the telltale sign on this one. However, this one could be confused for bilevel ovarian cyst because you don't see a large degree of enhancement. This is a much better one. And so, as you can see, there are septations, and there also looks like free fluid in the pelvic cavity, but there's enhancement. It is a heterogeneous type of mass. And so, based on the location, you would have to say that this is an ovarian cyst, or ovarian carcinoma, not an ovarian cyst, because of the enhancement that is in here. But I realize those can be confusing. So here is a little better. As you can see, there's still free fluid here, but you see a mass here, and it has septations inside of it, as well as the septations being enhanced by the contrast. And this one actually has, I think this is actually the same scan, but this one is just a little higher up because you're right almost at the acetabulum here, and you're a little more up in the pelvic girdle as well on this one. And so you have the entire transverse diameter of the mass seen there, and there is enhancement as well as septations in that mass as well. And so that would be the difference between an ovarian cyst and an ovarian carcinoma. And then we will get to cervical cancer. And the way that you can kind of tell a cervical cancer on CT is because it will be around the bladder. Whereas ovarian cysts are before you get to the bladder. This will be around the bladder. It will be it almost looks posterior to the bladder, but not always. But it looks like it's encroaching on the bladder. And this is a better demonstration of it. And as you can see here, they have just basically labeled this as the uterus because it is hard to demonstrate the cervix apart from the uterus. So you can't really say this is uterine cancer or cervical cancer, but for the sake of this, they say that it is cervical cancer, probably after ruling it out with some ultrasounds and things of that nature. But what you need to take away from this is that it has actually enhanced, and it is a heterogeneous density. The inside of it actually looks darker than the outside. And one of the telltale signs of cervical cancer is that it is pushing on the bladder. And so, and it is almost invading the bladder actually. As you can see, here's the bladder, And on the normal scan, the bladder will actually fill out this entire area. However, the uterus and the cervix has actually gotten so large that it is pushing into the bladder. So that is one way. Here is a PET scan with CT, so it's a PET CT, and it provides a hot spot for the uterus / cervix. And so you can pretty much tell that this has a high metabolic activity and it is absorbing a radioisotope. And because of that, it is actually demonstrated as a red area because of the metabolic activity. And here is another slide. This, I believe, is actually in your book. And as you can see, it is invading the bladder as well. It's actually pushing into the bladder. And so anytime that you see the bladder as well as the rectum possibly behind, and then you see something lying in the middle of it, that is going to be the uterus / cervix. And so anytime you see any abnormality there, that would be the cervix. And if you go above that, that would be the ovaries. So these are extremely difficult to kind of figure out which one it is. And that is why CT is not typically used for demonstrating these. CT is not as accurate as MRI when it comes to things of this nature. MRI is the preferred method of use for female reproductive abnormalities, whereas CT is more beneficial in terms of the renal system. So if you have any questions on this, just let me know. I'll try and make everything a little more apparent on the test, and there will be a test. That'll probably go online on Thursday. And we'll have till next Thursday, next Friday to actually move. So, but if you do have any questions, let me know. And the videos will be online hopefully by tomorrow.